Assalamu alaikum and good afternoon, everyone. This is Dr. Abdulmajid Zubaidi. I'm a cardiologist from Abu Dhabi here, and we welcome you to another session of the ECGs that we have been conducting for the last 2 or 3 years. And it had been well received by the community, our colleagues, physicians, primary care, nursing, all people who are interested in caring for patients with acute coronary syndrome. And the format of this ECG session is basically I give Dr. Bakir will give you his approach to reading an ECG. So he would go over the, an approach, a step-wise approach. And then I will come back and go through cases where we present a case, and then we show the ECG tracing, and then we go through the through a specific message to learn out of it. Is that either a diagnose, how do we, or what are the criteria to diagnose a STEMI? What are atypical criteria? What's a posterior MI? What's an RV infarction, and so on and so forth. So specific messages related to acute myocardial infarction. Again, the objective of this meeting or ECG meeting is, we all know that ischemic heart disease is the most common cause of death. So we have to do our work to help preventing that. And we all know another important fact is 12-lead ECG is an important tool in diagnosing MI. So if that tool, if people are not fully aware about how to read it and when to do it and so on, then that tool or those cases may not be able to be diagnosed early, and acute MIs can be missed easily. So the interpretation and the understanding of the limitation of the ECG is key in the diagnosis of acute coronary syndrome. Look at this slide and just to understand the value and the importance of what we are doing. So if you miss a case of MI, you don't diagnose it, the mortality can be up to 50%, because that patient, if you miss the diagnosis, the patient will not be treated appropriately. So most of these patients, they end dying, or their chance of dying is very, very high, 50%. While if this patient is diagnosed appropriately and he's admitted to the hospital, to a CCU, his mortality just goes down to somewhere in the 10–15%. If this patient goes for primary PCI, as you can see here, their mortality goes somewhere around 5%. So you're reducing the mortality if you do diagnose this patient very early and you treat them appropriately. You're reducing their death from 50% to 5%. Very robust and very significant results, of this diagnosis. Now, look at this case, just to give you a flavor on when ECG is not read proper, what can happen. So 38-year-old, so young person, with chest pain. Physical exam is unremarkable, and his basic blood work was not remarkable because of this chest pain, which is thought to be epigastric or reflex. The patient was treated as a reflex, and this is his ECG. ECG is, suggestive but not clearly diagnostic of a STEMI. So this patient was treated as a reflex, and unfortunately, the patient left the place. He was discharged home and to see a cardiologist on a follow-up, and unfortunately, he died after discharge from the clinic. Another case, the same thing, 61 epigastric pain, Basic blood work was unremarkable. And the ECG, as you can see here, done in one of the small clinics, the ECG is not very impressive. So, and we did talk about this, and if ECG is normal, sometimes it doesn't rule out. So this patient, the same thing, was sent home and was asked to come back if he got symptoms. 2 days later, he comes back with this massive inferior ST elevation and posterior ST elevation. So the initial ECG, and we'll talk about the importance of repeating the ECG, the importance of sometimes even admitting if the history is suggestive in the right patient. Another patient, 42, smoker, with upper abdominal pain, and he presents with dyspepsia. Unfortunately, this patient did not have an ECG, which was very unfortunate. So the message here is, if you have someone with chest pain all the way from the neck, from the jaw down to the umbilicus, I think he deserves an ECG, especially his 42 or 40s smoker or someone who got risk factors. This patient came back 12 hours later with this massive anterior ST elevation. Unfortunately, he died because if this patient was caught early, maybe there was a chance of saving his life. And last is the 62 presents with the left neck and shoulder pain, and his basic blood work was unremarkable. ECG was not performed because the impression was this is the shoulder and it was an arthritis. He was given NSAIDs and he was asked to come back if there's symptoms. And he presented a week later with these diffuse ST depressions. Of course, this was not a STEMI, but there was evidence of acute coronary syndrome. And this patient could have been diagnosed early, or he could have presented with a very bad MI. And now the distribution, a very important message. This is the distribution of angina. So the patient can present with angina, with pain or symptoms across all of this shaded area, or in one of them. So people can present with the jaw pain only, or shoulder pain only, or epigastric pain only. So you have to have some level of suspiciousness or thinking of coronary disease or acute coronary syndrome in these patients. And it's important to observe, to repeat ECGs, and maybe to admit despite negative testing if that is required. So the clinical use of ECG, and that's part of our objectives here, is to identify and characterize suspected cardiovascular disease. Risk stratification is important. Anterior MI is higher risk than inferior. Anterior or inferior with arrhythmias or with the RV infarction or posterior infarction. All of those are very, very helpful to risk stratify your patient and to decide how urgent and how much aggressive you should be watching and monitoring these patients, because he may get worse over a very short period of time. So you have to increase your competency, and this is the tools that can help you improve your competency. If you feel you don't there's a gap in your knowledge on ECG, don't feel bad about it. It's this is a study that was published in one of the Journal American Heart Association, and they show that residents, fellows, and even attendings or consultants can have gap, specifically when the criteria or the diagnosis is very subtle, very small. So sometimes the sensitivity can be down to 60 or 70% in certain cases when the ST elevation is not so high. So not knowing, or if you feel a gap, don't shy away. It's okay. You can, you have to improve your skills, especially if you're working in an emergency or if you're primary care physicians. Otherwise, you will be missing MIs, and this is something we don't want, and we don't want to be exposed to. So that's the, I hope I gave you a feel about the importance, missing cases, patients who dies, we see it almost, not so frequent, but we see patients who die who are diagnosed very late and they end with complications. And the reason is competency around ECG reading. So I think it's very, it's an opportunity to improve your skills and to learn more about the ECGs. Dr. Bakir now is going to take us to his slides, and he's going to show us his approach to reading and to read an ECG, and then we'll go back to our
Thank
slides.
you very much, Dr. Zubaidi. Now you can, I'm sharing now, you can see my slide now?
Yes, I can.
Okay. As Dr. Good evening, everybody. It's a great pleasure and honor for me to be with you today. And as Dr. Zubaidi said, we are doing this very frequently and continuous, and the feedback is very acceptable and good. Why we are doing this? Simply, as Dr. Zubaidi said, yes, everybody knows that chest pain is the characteristic for alarming you to say this patient have acute MI or not. And as we know, and as Dr. Zubaidi showed to us, muscle is time. You have to diagnose quickly, early, then to decide what to do for the patient. For all of us to understand the ECG and to have an idea how to interpret ECG, it is very important that you have to put a scheme in your mind. What does it mean? It means that you have to automatically, your brain interpret the ECG automatically based on the scheme you put it in your mind. What does it mean? Why we need, for any test, why you need the test? Simply because the test will give me the diagnosis, and also the same test can give me the prognosis, but also it is important to follow up. So when I decide to do any investigation for any test for any disease or any suspicious diagnosis, I have to choose the simplest, rapid, and the test which I can repeat. The second thing is this test should have high sensitivity to detect what I'm looking for, and the high specificity also to detect the problem which I am looking for it. So to understand, I have to put a scheme in my mind. This is a scheme you can tailor to yourself, but this is, I find it this way. When I look to
Dr. Bakir, can you share your slides?
It is not shared? Slide is not shared or what?
Yeah, it's not shared yet.
Just 1 minute. It's supposed to be shared. I asked you, it was telling me what happened. Just 1 minute. My slide was there.
I think your screen was up and then it went down for some reason.
I didn't do anything. So let me first to go out again. Let me go just here. Now you can see my screen, my slides. You can see it, Zubaidi?
No, still I can't see it.
You can't see it. Let me to go out and then come back again. Okay, I will go out. Let me to leave. I will leave and then leave.
So so waiting for Dr. Bakir to get, while waiting to get his.
You can see me now?
We can see you, but we cannot see your slides.
Maybe there's something in the chair. Where is send me share share screen. I am sharing screen now.
Yeah.
Share. Let me
excellent. Now we can see, but we can see your email.
Yes, I am downloading my email now because I want my slide. This is my slide.
I think you're sharing the whole desktop.
You can see my slide now?
No, we're sharing your screen, your email, your slide, your.
Still you are sharing my email, not a slide?
No, yeah, your email.
Very strange.
I think you're sharing your desktop.
Doctor, can you please stop sharing and
Stop
choose
sharing.
and open first your PowerPoint? Open first your
My
PowerPoint.
PowerPoint, hey, it's ready. Now this is my
Okay,
PowerPoint.
and minimize and click minimize on your PowerPoint.
I'll minimize it and then share screen, yes?
Okay, and share screen and choose PowerPoint, not your
No.
screen.
PowerPoint. I'm choosing PowerPoint. This is what we are doing every time. Close the, where is my PowerPoint?
دكتور حضرتك لما بتدوس على الشير سكرين بيبقى فيه اوبشنز، حضرتك تختار السكرين بتاعت حضرتك او تختار الباوربوينت لو حضرتك فاتح
الباوربوينت. This is what I'm sharing now. Okay now?
Okay. Yeah, go ahead.
هي دلوقتي يا دكتور اشتغلت.
خلاص.
Okay now?
Now you can go ahead. Yes.
Okay. So I have to go quickly for this because
Oh
of time.
yeah. So just go as every time it's rate.
Yeah. Quick.
And then
so first we have to know the rate, rhythm, axis, interval, segment, and others. What does other mean? Bundle branch block or any other abnormality or any ischemia on prolongation of the QT interval. So if you put this scheme in your mind, the rate, rhythm, axis, interval, segment, others, you will able automatically, your brain will automatically see the ECG. This is very important, as Dr. Zubaidi said, that first, when you said ST elevation, this is there is some criteria. You have to look to the J point. Dr. Zubaidi will discuss it during the cases. But just to tell you how to look to the J point, I will not spend time because of the time, because we already delayed a little bit. So you have to decide where is the J point, and based on that to measure your ST segment. There is very important what we mean by ST segment. It's ST segment represent the phase of cardiac cycle, so I will not go through it. But this is the J point. If you look here after the QRS complex, and you can see the ST segment elevation or depression. And this is to show you what we mean by ST segment elevation at the J point. It should be more than 2 millimeter in the chest lead or 1 millimeter in the standard lead. And then, for example, also another important point recently it have been discussed that if you find ST segment elevation in the AVR, this is by its mean. This is talking about left main disease, and this is will be discussed in some of the cases. Remember when to record additional lead, like for example, V7 or V9, you have to go to the posterior lead. This is very important because this is will give you about the posterior myocardial infarction. And also you have to know that when you are putting your lead, V1, V2, V3, and go back, you are seeing the heart from different angle. Also, another important point, remember when to record additional lead, like V3 and V4 right, this is patient with inferior lead to identify the right ventricular infarction. And this is to give you an idea about the baseline and the elevated ST segment. So this is the normal, this is the peak T wave, this is showing you the progressive ST segment elevation, and this is to show you the loss of the R wave and the T wave, and because all of this will give you the time from infarction, because sometimes the patient come to you with chest pain, but they have also 3 days ago an infarction and now came with another pain. So this is very important. And also we have to know that hyperacute T, it is very important. And also not to forget the hyperacute T with ST segment depression in the precordial lead. This is important. Well, in science, some people are interested in the sign. This is to give you an idea about the what is going on. So in a very quick, we have to know that this is the nomenclature when you are seeing the R wave small or QRS or QS pattern. This is important. There are very important 10 rules. I will go very quickly on these 10 rules for the normal ECG. The rule number 1, PR interval should not be more than 120 to 200 millisecond or from 3 to 5 small square. This is very important to say if there is short or prolonged PR. Second rule, which is very important, the P wave should be upright in lead 1 and lead 2 and V2 to V6. This is very important because other than that, sometimes you will find P wave inverted in V1 does not mean anything. So you have to understand that. Rule number 3, the width of the QRS complex, it should not be more than 2.5 small square. If it is more than 3 small square, you are talking about wide QRS complex. Rule number 4, the QRS complex should be dominantly upright in lead 1 and lead 2 and from V the QRS should be QRS pattern from V1 to V and the QR pattern in V6. This is very important also. Rule number 5, the QRS complex and T wave should have the same direction. If you find it against, this is very important to have the same general direction in the limb lead. So the T wave and the QRS complex will be the same direction. Rule number 6, which is very important, all in AVR, all will be negative. And if you find ST segment elevation in the AVR, you are talking about left main disease. Also, from V1 to V6, the R wave in the precordial lead must grow up from V1 to V4. Why? This is because of the horizontal lead. Like this, you are looking for like this. So you will find that the R wave in the precordial lead must grow from V1 to V4. And the S wave must be smaller from V1 to V6 also. Rule number 8, the ST segment should be start isoelectric except in V1 and V2. What does it mean? Which means that sometimes you can find in V1 and V2 ST segment elevation. Does not mean there is myocardial infarction or ST segment elevation. You have to be aware about that. Rule number 9 should be no Q wave or normally small Q wave less than a small square in lead V1 and lead 2 and from V2 to V6. If you find there is tall or there is or more Q wave, you are talking about all the infarction. Rule number 10, the final one, T wave must be upright in lead 1 and lead 2 and from V2 to V6. So characteristic change in the acute MI, ST segment elevation, ST segment depression in the lead opposite to that, which means reciprocal change. And Dr. Zubaydi will show you some cases, pathological Q wave and reduced R wave and inverted T wave. So this is quickly the ST segment elevation time. By time, it is the drop and the Q wave start to appear, and then Q wave become more appear, and the ST segment depressed by time. Also, we have to know to differentiate between left bundle and anterior wall infarction. This is very important. We'll talk about it during our discussion. And the left bundle branch block, this is to differentiate it from acute myocardial infarction. And I have to stop now, Dr. Zubaydi, I think, for time. Dr. Zubaydi.
Yes.
I think I will give you.
We can move to
the cases.
Yeah, we can start. You can go to the cases. I mean, remember that this is a very interactive. It's it's informal, and the way we will be doing it is
just I will give a quick, Dr. Zubaydi, about the axis. Usually for the axis, lead 1 and the AVF should be upright. This is the normal axis. If you find that lead 1 is positive and the AV1 is negative, the RS is deeper and the R wave, which means they are checking hand with each other. This is called the right axis. And if you look to the left axis, usually it will be away from each other, V1 and AVF, but you have to look to lead 2. If you find lead 2 is negative, this is mean pathological left axis. And the infarction, as you see, it will be discussed during the location of the infarction. Yes. Dr. Zubaydi will discuss. I will stop sharing now. Okay.
Yeah, so remember that the format here is I'm going to share the, some ECG tracing, some cases, and we will read them and
so
according to that approach, Dr. Bakir, can you get out of the stop the sharing?
I'm trying to stop the sharing. Let me down. Sharing. Stop sharing. I stopped now. Okay. I'm sorry for the delay which happened, but this is some technical.
Sure. So what we'll do is we'll show the case, and then I will ask you, Dr. Sharif, to read it, and we'll go over the tracing of the ECG on a stepwise approach, and so it can be informative. And then at the end, we'll give a message out of that ECG. So this is a 64 male diabetic smoker, comes in with a chest pain, and presents to an MPCI hospital. So 30 minutes to reach PCI capable hospital. So usually if someone, if this case is going to be a STEMI, usually if the if the patient presents to a hospital that is close to a PCI hospital, then that patient should be transferred there. So the one first message out of this is you have to be familiar, you know, when you're having a clinic or you're in an emergency department or you deal with patients with chest pain, you have to be familiar with the PCI centers in your region or your city. So it's not the time to figure out who's going to take that patient when he comes in, you know, while after the diagnosis. No, you have to be familiar with it. This is part of your, you know, basic knowledge to treat an acute MI, is to know how to triage them and where to send them. So remember, not the time to learn about it when you are after you do this ECG. So this is the ECG. We'll go over this ECG.
Let us to go, Dr. Zubaidi, with this ECG. Number one, the rate. What is the rate? You can calculate the rate.
So the rate here is about, I would say, somewhere around 100 plus, according to your approach. I mean, you know, if you use the large squares or all the different methodologies. So if I'm to guess, yeah, it's about more than 100.
Yeah, because the distance between the RR can calculate the big square.
Yeah.
And if it is so fast, you can calculate the small square. Big square, 300 divide the number, or a small square, 1,500 divide the number. So the rate here is around 100 or a little bit more.
Yeah.
It's
regular. It is regular.
Yeah. HP followed by QRS complex. Yes. So it is a regular risk. Axis, if you look to the axis, you will find that lead 1 AVF, they are away from each other. But if you look to lead 2, the R is more than the S. So this is normal axis.
Normal so regular sinus rhythm with the normal axis.
So rate rhythm axis interval. If there is any PR interval or QT interval prolongation, it looks like
I don't see anything significant. So this is the PR interval. It starts from the start of the P all the way to the start of the Q, and the PR interval is normal.
So rate axis interval, and then segment. This is the most important.
In this case, you know, what we're looking for is those segments, the ST segments, and it is in the after the J point, and there's obvious ST segment elevation involving lead 2, lead 3, lead AVF, and then there's some ST depression involving V1 and V2, and then lead AVL here, maybe lead 1. So ST elevation in the inferior leads and ST depression involving the lateral and some of the anterior leads. So
when we see ST segment elevation, this is talking about possibility of myocardial infarction, and to confirm if you find ST depression in the opposite lead, because this is called the reciprocal exchange.
Right. So in this ECG, I think what we have is inferior so sinus rhythm, regular rhythm, slightly tachycardic, because above 100, and the axis is normal, and there's ST elevation involving the inferior lead. So we went systematic and we read the ECG. Now the ECG criteria for a STEMI. So when do you say that this patient has ST elevation MI based on the ECG criteria? So the patient will come in with a chest pain, and then the ECG demonstrates any of these features, then that's, you treat that patient, as a STEMI. So ST elevation of more than 2 millimeter in lead V2, V3, or 1 millimeter in 2 other contiguous leads, or if the ECG shows new left bundle branch clot, and the clinical status is suggestive of acute MI, of course, which is chest pain or symptoms. So if you have someone who presents with those ECG criteria, then now you're dealing with ST elevation MI, and you need to treat that patient accordingly. So the best, of course, is transferring him to a primary PCI site if you are not a PCI site. Of course, you need to load that patient with aspirin, with antiplatelet therapy and heparin, and put him on a monitor, and then send him to primary PCI. Monitor is very important after you diagnose such cases, because these patients are at high risk of having a ventricular fibrillation. So if you don't hook the patient to a monitor, you may lose these patients because they can go into arrhythmia at any time. They can go into a bradycardias or tachycardias, any type of bradycardias like complete heart block or arrhythmias or ventricular arrhythmias. So, and we'll talk about this later on. So case number, any message, Dr. Sharif?
No, I think this is, so the take home message, ST segment elevation mean whatever evidence of doubt, consider it as myocardial infarction, send it directly to a place where is a cath lab. If available, you can say that Dr. Zubaidi said 90 minutes, you have to finish. If it is a little bit far than the hospital you are in, you have to do it about 120 minutes. What do you think, Dr. Zubaidi?
Yes. So that's the key message. Says you need to send that patient to for reperfusion therapy, and we showed that on the first slide in the introduction. If you treat these patients, if you don't treat them appropriately, their mortality is very high. The chance of dying is very high. If you treat them appropriately, the chance of dying is very low, according to the evidence-based treatments that we have so far. So case number 2, so we don't go late. Male, 56. Okay, he has atrial fibrillation, diabetic, hypertensive, dyslipidemia. So he got multiple risk factors, and now he comes in with chest pain and dyspnea, no past medical history. So he comes in, and first thing you will do is you'll do an ECG. ECG.
This is looks a very terrible ECG.
Very terrible ECG.
Okay, rate, rhythm, axis, interval. Can you comment on the rate, Dr. Zubaidi?
So the rate here is very slow. So it's a bradycardia, and it's irregular. That's why we can't calculate it based on the standard of the large, squares. But what we can do is we can count.
You see any P wave?
The number of QRS complexes. I can't see P waves. So this patient has atrial fibrillation probably, and he has irregular QRS complexes, and I can't see a P wave. So probably this patient already from the history. Yeah, so already from the history, he has atrial fibrillation. So we know he got AFib, and the ventricular rate is very slow, as we can see here. And the second part is, so he's irregular, he's bradycardic, his axis is normal because both lead 1 and AVF are upright, right? And then we go to the intervals. The intervals is, there's no PR, but there's a QRS interval, and the QRS interval is very wide. And
because we said that it's more than 2.5 small square, it is wide.
Yeah, so the squares, Dr. Bakir, you're pointing out is those small squares between the large ones, is
2.5 small square. It is more. This is the normal. Above 3, it is bundle branch or wide complex.
It represents more than 120 milliseconds. That represents a wide QRS complex, suggestive of either a right bundle, left bundle, or some sort of a ventricular conduction problem. In this patient, the pattern of the widening of the QRS complex is the left bundle branch block. So we have a regular bradycardia, a regular rhythm with the bradycardia, atrial fibrillation with a slow ventricular response, and a 12-lead suggestive of a left bundle branch block. So
just one interruption, Dr. Zubaidi. If you find in left bundle branch block and you don't have any previous ECG to compare, this is to be considered as acute myocardial infarction. Agree with me?
Yes. So patients, we described in the first ECG the typical STEMI, so chest pain and ST elevation. Now we have cases that can, have a similar presentation to a STEMI, but on the ECG they are atypical, and this is one of them is left bundle branch block. The patient comes in with with chest pain and left bundle branch block. Now, if you can determine the age of the left bundle, then this is a STEMI till proven otherwise. And this patient, we have an old ECG, which is 1 year ago, and this is still atrial fibrillation and rate is ventricular rate up, but not widespread. Yes. So the left bundle branch block we saw on the ECG when he presented, we will treat it as new. And if you have a new left bundle branch block, then it's a STEMI. If this ECG, the old ECG was a left bundle, then you would not treat it as a STEMI. And so there is patients, and this slide comes from the European Society of Cardiology. And what they have on this slide is they say atypical ECG presentation. So bundle branch block is one of them. And of course, I mean, you can diagnose STEMI based on the ECG of a patient with the left bundle branch block. And those criteria are described in New England Journal a long time back, and they're called Scarboza criteria. You can use them, or you can just say, you know, if I have an ECG with the left bundle branch block, I'm going to treat it with an acute MI till proven otherwise if I don't have an old ECG. So another challenging scenarios to diagnose a STEMI is ventricular paced rhythm. So patients with pacemakers, it may be difficult. Another scenario also that you may have ST elevation, but difficult to diagnose on the 12 lead is isolated posterior MI. And unfortunately, we don't have an example here, but it's, you know, you have a ST depression in V1, V2, V3, and you have to do a posterior lead to demonstrate ST elevation. So posterior infarction is atypical, left bundle is atypical, paced rhythm sometimes atypical. Another scenario is ischemia due to left main or multi-vessel, and these patients can present with ST depression in 8 or more surface leads. So a lot of ST depression across with ST elevation in AVR, but remember that this is not specific. So recently I had a patient with AVR ST elevation because of severe anemia, or AVR ST elevation because of myocarditis or pulmonary embolism. So ST elevation in AVR just indicates a global ischemia. It can be a supply or it can be a demand ischemia. So those are the atypical presentation of acute MI. Any comments or messages, Dr.
No, Dr. Bakir, Dr. Zubaidi, I think this is very clear. But as we said, it is we have to be sure about if new onset or old onset left bundle branch block to consider what we are going to do. Okay.
Okay, excellent.
Now
let's move. Yes, let's move to case number 3. So, so we talked about the definition of ST elevation based on the criteria, not typical and atypical. Now let's see this case and the message out of it. So 44 male with 2 risk factors, which is hypertension and diabetes. Now he comes in with a chest pain and dyspnea, sweating. So this patient deserves an ECG, no doubt, you know. So you get the ECG done, and this is his ECG. So rate, rhythm, axis, and intervals and segments. Rate, probably about 100 or less. صح, Dr. Bakir?
Yes, rate here, if you calculate the, no, it is less than 100.
Less
because
than 100.
If you look 4 big square, so it will be around 80 or something like that.
And it's regular?
Yeah, rate, rhythm, axis. The axis looks, if you look to the axis, it's normal axis. Rate, rhythm, axis, interval looks normal, but there is ST segment depression and the elevation. Can you comment on that?
So we talk. So yes. So the ST segments here, you know, if you look at lead 1, look at lead AVL, and then look at the anterior leads, which is V2 and V3, and obviously there is an ST elevation. Going back to the criteria from the first ECG or the first case, we said more than 1 millimeter ST elevation in the precordial lead, more than 2 millimeter in the chest lead, specifically V2, V3. And I think this patient meets those criteria. So there is an ST elevation involving the anterior and then the lateral. And then there's ST depression involving the inferior lead. So anterior, and then here, this case, I'm going to show you the localization, what we call localization. So you have to be familiar, first thing, with the diagnosis. The second thing is with the regions or the localization of the MI, because some regions have a certain complications and certain outcomes. Usually anterior MI is very bad in terms of prognosis compared to inferior MI. Isolated lateral or isolated posterior is lower risk compared to massive anterior, or anterior with posterior, inferior posterior. Those are high risk also. So lead 1 and AVL is lateral, 2-3 AVF is inferior. These leads they present lateral, and then the V1 or the precordial lead represents the anterior segments. And this table basically gives you this what I just stated. Now, for the interventionist, it helps us identifying what is the culprit. Most of the time, the culprit is straightforward. You don't have to spend any time finding it. But occasionally and rarely, you may be confused as to what is the culprit. If you have a chronic occlusion somewhere else, then the ECG sometimes will be very helpful in identifying the culprit. The second part is the prognosis. You know, the more ST elevation, the more the leads, the more the ST elevation segment, the higher the mortality and the higher the chance of complication. So what is required from me or from you? The requirement is you have to act fast. You have to treat this patient urgently. You have to make sure that they are anticoagulated. They receive their antiplatelet. They are on oxygen. They are on monitor. Sorry, they should be on monitor hooked as early as possible, especially if the patient is having a bad, a bad prognostic factor there. You have to be close to the patient. So if you're in a small hospital, don't get busy with other things and forget about such high-risk patients. Any other comments, Dr. Bakir, before we move?
No, I think it's okay. No comment.
Okay, great.
So we'll go to the fourth case. Yes.
We'll go to the fourth case. So the fourth case is 69 male, okay, diabetic, smoker, presents with chest pain, sweating. So this patient deserves an ECG, no doubt, okay? So this is his ECG. Another ugly ECG.
Yeah,
so,
this is a very bad ECG, Dr. Zubeidi, as you see. If you apply rate rhythm axis, let us start by the rate. It is very slow. This is very severe bradycardia.
So about 40.
Okay. And then is this sinus?
It doesn't look like, because I can't see P waves. I see some deflections here after the first QRS complex, but it's not consistent. So maybe there's a very slow sinus rhythm or sinus rate.
I think if we consider,
but definitely it is dissociated.
Yeah.
It is dissociated from the ventricular complexes.
Yeah.
No,
I can't. This is very ugly. So rate rhythm axis.
Yeah, before every QRS complex, there's no P wave. Carry on. P wave.
Axis, there looks like normal axis.
Yes. Yes, it's normal axis because we have positive lead 1 and AVF.
So ST segment usually elevated. So what is the diagnosis in the inferior lead?
Yes. So we have some sort of an AV block, most likely a complete atrioventricular block, and the ventricular response is very slow with a ventricular rate of maybe 40 or less. There is ST elevation evident in lead 2, in lead 3, lead AVF, ST elevation, and there is a ST depression involving the posterior, the V1, V2, and V3. Another important thing here is there is a dominant R wave in lead V1, V2, and V3. Okay, dominant R waves, and those are suggestive of posterior involvement. So if I am to conclude on this ECG, I would say this is an inferior, because 2-3 AVF is involved, posterior because V1, V2 has ST depression and dominant R wave. So inferior, posterior MI.
But also, you have a reciprocal change, yes?
Yes, yeah. So there's a reciprocal change involving AVL and lead 1. So inferior, posterior ST elevation complicated with complete AV block. So this patient needs any other thing, Dr. Bakir? So inferior, posterior, STEMI complicated with complete AV block. Yes.
Yes, Dr. Zubaidi, so no comment.
Yes. So this patient, I think he should have, an urgent attention. He needs a monitor. He needs to start thinking about, depending on his hemodynamics and blood pressure, about pacemaker, of course, the aspirin, antiplatelets, and heparin, and then urgently transferred to a cath lab where he can be reperfused and hemodynamically supported either by pacemaker first thing, and then it depends on if he needs any other hemodynamic support, either medications like norepinephrine or dopamine or any other hemodynamic support. So this patient has inferior STEMI, and inferior STEMI can be complicated with, as we saw here, with AV block, can be complicated with RV infarction, can be complicated with the bradycardias. So RV infarction happen in 40% of inferior MI, inferior myocardial infarction, especially if the RCA is occluded from the proximal part. And it's easy to diagnose it on 12 lead, or most of the time it's easy to diagnose if you see an elevated ST elevation in V1, and then you do right-sided ECGs and you'll see it. Bradycardia, because the right coronary artery perfuses the sinoatrial node artery, and heart blocks can occur. AV block, we saw it on this ECG. So remember, it's a STEMI, and it is the complications of the STEMI that you need to be looking for. So watch for the complications. So of course, I mean, such patients, do you need to give atropine? Do you need to give dopamine, norepi? All will depend on his hemodynamics. If the hemodynamics are slow or low, if the systolic blood pressure is less than 90, if the mean arterial pressure is low, say less than 65 or less than 60, then you start to worry about perfusing the organs, and then you need to be aware about that. This patient needs some support for his blood pressure. So first thing, you can give atropine. Some people are controversial about it, but I would give, and go from there. But definitely the most important is sending him to the to a place where there is a cath lab. So the message is inferior MI can have a lot of complications, and those are the list of complications they can have. You have to be aware about them. Case number 5, male 39 with multiple risk factors, presents with chest pain, no other medical problems, and this is his ECG. We talked about these complications, so now we have it. Inferior, remember about the complication of inferior MI. We don't have a tracing here, any lead 2 tracing, but we can use the 12 leads to read the rate and the rhythm, Dr. Bakir. So I don't know, Dr. Bakir maybe is not hearing me. So what we have here.
I'm hearing you.
You are hearing me.
Yeah.
Excellent.
So rate rhythm axis interval, shall we set
Why
the
don't
rate?
you do that for me? Do that for me.
The rate is, if you look, three small square. So we are talking about around 100.
Okay.
And axis is normal, lead 1 and AVF. And there is rate rhythm axis interval. The interval looks normal. There is no prolonged QT or prolonged PR. But we have ST segment elevation in the inferior, lead 2, 3, and AVF. And in the same time, we have in V1, V2, and also V3, okay? And with ST segment depression in lead 1 and AVL. What does it mean? It means that we have inferior, anterior with reciprocal chain in the lateral lead. Are you agree with me?
Yes.
And also V5 and V6, ST segment depression.
Yes. So this case has an inferior ST elevation complicated with what it looks like an RV infarction, because focus on lead V1 and V2, and you can see there's ST elevation in those 2 leads, and those ST elevation suggests that the right side may be involved, the right ventricle. So the next step, if you want to confirm it, just do right-sided leads, and the right-sided leads, I'll show you on the next slide. What does that mean? So right-sided leads, if you look at, so this is those leads. So you would ask your ECG technician or the nurse who works with you or the person who performs, if you're the one, just what you need is you need to put the leads on the right side of the chest as compared to the standard ECG where we put it on the left side of the chest. So then look at those leads, and if you will see ST elevation, and that will help you diagnosing a right-sided infarction. Then why do we need to know about right-sided infarction? The thing is, with RV infarction, the patients are prone to shock and hypotension from the poor pump of the right side. And we have to be careful giving them nitrates. If you give nitrates, they will drop their blood pressure more because you're reducing the preload. The second message after the nitrate is giving them fluids. These patients, they respond very well to fluid. So push fluids, boluses, and watch carefully, challenge them with fluids, and usually they do respond to fluids. So this is the inferior STEMI with RV infarction. Any more comments, Dr. Sharif?
Hello.
Yes. Any more comments?
No. It's excellent. So we'll go to
next case. Okay. Next case, 56, female, multiple risk factors. Okay. She presents with chest pain and sweating, non-PCI hospital. But this non-PCI hospital is far away from a PCI hospital. Say in Abu Dhabi, someone presents to a hospital in the Western region or Gharbiya, what we call it. Those hospitals are very far away. Sometimes it's not easy, not accessible to a PCI hospital. Of course, you have to have a protocol to transfer, but definitely by the time they arrive, it will be already late. So you may have to think about thrombolizing these patients. So this patient came in with this ECG.
Okay.
Dr.
Let us to start again. Rate, rhythm, axis, interval. I'm trying to repeat the scheme so everybody can keep it in his mind. So the rate, what is the rate? So we'll see between RR interval, they're around 3 big square with 1 small square. So it is less than 100. Rhythm, yes. It is sinus. Yes, there is P wave before each QRS complex. So it is regular sinus. The axis looks normal, look to lead 1 and the AVF. So rate, rhythm, axis, interval. Looks interval, there is no PR interval or Q interval prolongation, and the QRS complex are normal. Now we'll go to the segment. We have huge ST segment elevation with peak T wave in the anterior lead and also in the inferior lead. Agree with me, Dr. Zubaidi?
Yes, definitely.
And in V1 to V2, V3 and VF, there is a Q wave. You get the point? So the question is, this is inferior, definite inferior, but what about this anterior? It is old, new, something like that. What do you think?
For which one? For the anterior. The anterior looks hyperacute, the T waves, although there is already, the R waves are already down, which sometimes indicates a delay in presentation. Or a late presentation or an old infarction, but the hyperacute makes me very suspicious that this is an anterior. Yeah, it's an acute anterior, and then the inferior ST elevation. The inferior ST elevation can be explained, Dr. Bakir, by what we call wraparound LAD.
Yeah, most probably this is wraparound LAD, and you look also to the AVL. And in the V6, there is some ST segment depression indicating that there is reciprocal change. Yes?
True. Yes, exactly. So those ST depression are reciprocal changes. But this patient, again, anterior ST elevation with inferior also ST elevation. And we see those, I mean, of course, this is a high risk patient. And as a wraparound LAD, it means that the LAD supplies the anterior wall, and then it goes around the apex and it wraps around, and then it supplies part of the inferior wall, if not a big part of the inferior wall. And those are the type 3 LAD. The LAD is so big that it goes around and it supplies part of the inferior wall. That's why you see ST elevation. If it's occluded, you will see ST elevation in the anterior because there's an anterior injury and then inferior injury also. So so that's someone commented, say it's a left dominance. Yeah, so it depends on how you define what is a left dominance. We call it type 3 LAD, which is a large LAD, because left dominance sometimes can be it can be meant or interpreted as a left dominant, but means the circumflex is dominant compared to the right coronary artery. But this is an anterior, and the most likely the culprit here is the LAD, proximal LAD. Dr. Bakir.
Yes, I totally agree. And I mean, what is the take-home message, Dr. Zubeidi? Someone like this, even if you have Q wave, you are not still the ST segment elevation. So you have to take this.
Yes, definitely.
Because somebody will say Q wave already there. No, we have to respect the ST segment elevation. Yes. Okay.
So this is this is a very high risk patient because you're involving anterior and inferior, you're involving two large areas of the myocardium. Practically, this patient, if you follow them, they will gradually go into cardiogenic
shock. What is the mortality rate, Dr. Zubeidi, if he's not done reperfusion?
This patient, if they're not treated properly, their chance of dying is extremely high. I showed the slide at the start of this meeting, and patients who are not treated, who are not diagnosed, say for such a patient, their mortality can go up to 50%. If they are admitted, and of course it depends on if they are treated and so on, it can go down to 10-20%. If this patient develop cardiogenic shock, cardiogenic shock mortality is 50%. In the best trials, on the most recent trials, and with optimal treatment, balloon pump, mechanical support, and devices, reperfusion, all
so the take-home message, quickly to the cath lab.
Exactly. So you have to urgently interfere and react and triage this patient. Otherwise, they will get into shock, and then it's difficult to get them back. Shock is a spiral. So a few messages that I thought are relevant and important to know. 12-lead ECG recording and interpretation is indicated as soon as possible. The guidelines, now this is the European Society of Cardiology, and if you go to the American Heart Association and American College of Cardiology guidelines, and any other international society that you believe in or you want to follow, ECG for chest pain patients should be done within 10 minutes from the time they walk into the emergency department, or from the time they say they have chest pain. ECG monitoring with defibrillator capacity is indicated as soon as possible in all patients with suspected MI. So we talked about this early, because these patients are at high risk. They can develop arrhythmia at any time. They can go brady, they can go tachy. And sometimes you may not be able to tell because if you don't have a monitor in place. So you have to have the monitor, and that monitor has to be clear. The display has to have a clear display to show you the rhythm, so you can react if the patient goes into any bad arrhythmia or any complication of their MI. Additional posterior leads in patients with high suspicious of posterior infarction is also important. Right-sided leads can help in diagnosis RV infarction. Another very important message I want everyone to be alerted about is some people would send routine blood sampling for troponin or for CK in patients with the STEMI. This is not required. You're doing it for prognosis, but not to diagnose, not to decide about the treatment. If you have a ST elevation on ECG, you have to react and get the patient to a cath lab or to reperfusion. Don't wait for the troponin. Troponin in STEMI, the role of troponin in STEMI is not diagnosis, it's prognosis only. So it can come later on and you can make a decision about it, okay? So troponin, remember, don't order troponin and wait for the results. Don't wait for the results, just act and treat your patient. Sharif, what do you think?
Okay.
Great. Case 7. So male, 44, smoker with dyslipidemia, has chest pain, swelling, and dyspnea. He had an angio and 3 years back. We don't know any details. So this patient already had, maybe had a stent, maybe had, so he's a high risk to start with. So, you know, don't say, oh, 44, he's young. No, ECG is very important. So, oh, you did the ECG, and the ECG, if we go systematic, what do you think? ECG, while you are
ECG is, let us to go again.
protocol, protocol, sorry, l'approach تبعك دكتور شريف.
Rate, rhythm, axis, interval. This is very important ECG. Why? Number one, what is the rate?
Rate is, yes.
4 big square, yes?
4, yeah, so 75.
Okay. Rhythm,
Rhythm is
PQRS
regular,
complexity,
regular.
PQRS complexity.
Yes.
Axis.
Normal axis, lead 1 and AVF are up.
Okay. Interval.
Intervals, they have a PR interval, like the P to the QRS, it looks okay.
Normal.
Yeah, normal. All of the QRS is normal.
Normal.
The QT is normal, yes. So
Segment.
PR, so when we say intervals, PR, QRS, and QT. Okay,
Yes.
ST segment.
Look, only you have some doubt in V1 and V2, but otherwise looks normal. So why you are showing this ECG in this is
so that's what I say. So this patient is a high risk. This patient is a high risk. He had a PCI sometime in the past. He has multiple risk factors. Now he comes with chest pain. His ECG is normal. Are you comfortable, Dr. Bakir, to send
this patient?
home? Yes.
Yani he came with chest pain.
He had PCI 3 years back.
Yeah.
He has multiple risk factors. His ECG is normal.
Should I discharge this patient from the ER because ECG normal? The answer is no.
No. Okay,
why
no? Now,
why no?
Why no? So I'll show you his ECG just 30 minutes later.
You see?
So that's his ECG 30 minutes later, Dr. Bakir.
So complete different, yes?
Yes. So can we interpret?
Yeah. Rate, same, does not change. Interval, rate, rhythm, same. Axis.
Some QRS complex or with an ectopic here, a single ectopic.
So rate, rhythm, axis.
Axis
in the
is normal.
There is one ectopic beat, and the ectopic beat fall on the T wave. Very dangerous. Yes.
Very dangerous. Yes.
Yani ventricular premature fall on the T wave, the very vulnerable period.
Yes.
Yes. Okay.
Yes.
The second thing also segment. Now we have ST segment elevation and ST segment depression. Elevation is not so clear, but there is ST segment depression and T wave in lead 1 AVL. But look also to the V2 and V3. So what is your interpretation, Dr. Zubaidi?
So definitely, so this patient within 30 minutes, we had an ECG that could have fooled us and led us to a different path. But, he was lucky, and the physician who looked after him and took care of him, was fully aware that the normal ECG does not rule out acute coronary syndrome. And he repeated the ECG 30 minutes later when the patient developed chest pain. And obviously there's ST elevation in inferior leads. It's subtle, it's not so, dramatic, but there is. And then we have ST depression involving the anterior leads, which is suggestive maybe of an inferior posterior ST elevation MI. And the patient already, the myocardium is getting irritated and irritable because we can see now PVCs, and those can trigger any type of arrhythmia like a ventricular.
Just Dr. Zubaidi, I want to add something very quickly. Before the development of cardioversion and this sick, 50% of the patient with myocardial infarction before admitted to ICU, in the past, they die before reaching the hospital because of VF. And after that, after the initiation of the ICU and the defibrillator, the treatment or the mortality rate have markedly dropped. Why? Because this kind of premature.
Yes. So this is actually a good message also, is still a lot of our patients, we lose them before they get to the hospital. So acute MI is still a killer. You know, it's a very, it can have a bad, you know, in a good system, in a good healthcare system, still about 40% of the patients, they die before they arrive to the hospital, before they see any medical profession, before they see any medical personnel, because the reason is the myocardium, you know, gets ischemic, irritated, and they develop arrhythmia, VF, and they die, or a hemodynamic collapse, and they die. So this patient, normal ECG does, the message out of this case is the normal ECG does not rule acute coronary syndrome.
Imagine, Dr. Zubaidi, if this patient was discharged from the whatever clinic and died in the street outside, what will be happen for the doctor after in the investigate?
Well, here, I mean, this case, of course, I mean, it is, you know, because of the clinical scenario, I think the physician, the person, whoever, you know, that person is liable, because, you know, acute coronary syndrome is a clinical diagnosis, not ECG only. ECG helps, but you have to use your clinical sense. So someone with multiple risk factors, had a previous PCI, presents with a chest pain, that is enough for me to be, you know, to investigate this patient and make sure he doesn't have ACS before I send him home. ECG by itself is not enough.
Yeah.
So this statement comes out of the European Society of Cardiology guidelines, and I copied it from there. So what does it say? ST segment depression. It says ST segment depressions or elevation or T-wave inversions increase the likelihood that the discomfort is due to angina or ACS. Okay, so their presence helps you to diagnose. However, the lack of these findings should not rule out angina as a cause of chest discomfort. The initial ECG has a sensitivity only of 20 to 60% for MI, let alone the presence of coronary disease. So don't be fooled if you have a normal ECG. Normal ECG does not rule out. Abnormal ECG helps you, but normal ECG usually doesn't help in ruling out. Okay, I hope this message is very clear, you know.
And this is very, very, very important. Thank you, Dr. Zubaidi, for this ECG.
Okay. Case number 8. Case number 8 is a male, 48, with dyslipidemia, smoking, and family history. When I see family history, I don't know, Dr. Sharif, you have the same concern. When I see a family history,
don't be misled by the young age. Don't be misled.
When I see family history, when I see a family history, usually it makes me worry more, because in young age, especially, you know, I take those cases very serious. You know, those chest pains. So chest pain, palpitation, past medical history is not significant, and that's his ECG. So what do you think?
I don't know what's happening.
Okay.
What do you think? We have a noise in the background. I don't know who's that. Please mute.
Some background, some people was talking. I don't know.
Yeah.
So this is an ECG showing rate, rhythm, axis. Let us to see. Rate, what is the rate? It is at least 4 big square. No, 3.5. So it is at least less than 100, more than 80. Rhythm, sinus, PQRS complex. Axis looks normal. Interval looks normal. But now we'll go to the segment. What's your comment on the segment, Dr. Zubaidi?
So segments, and when we say segments, usually say PR segment, ST segments, but for this, for tonight, usually we're focused on the ST segment. And ST segment here, you know, the first thing, of course, striking is ST depression V1, V2, V3, V4, and then there's some ST elevation involving the precordial leads, which is lead 2, 3, or lead 2 AVF, and maybe lead 1 and AVR. There's a lot of movement, but this ECG is suggestive of inferior and a posterior infarction. You can see those ST depression in the posterior leads.
And the lateral lead also, Zubaidi, lead 1 and V6.
Yeah, definitely.
1 AVL, V6.
Yeah, sorry, I got busy with all these leads, so I forgot about those. They're far behind there. Yeah.
Yeah.
So actually the message out of this is just those leads. So inferior, some ST elevation, but definitely posterior, there is ST depression. And I think we need to, if you see those ST depression, think about posterior infarction. Already V6 elevation is suggestive of posterior infarction. So that's what we did. Now look at V4 here, 5 and 6. This is just the naming is wrong for our colleagues who are on the who are watching us. V4 means posterior leads, not V4. It's V7. V5 means V8. V6 is V9. Okay, so you just you know, because on the previous ECG, you know, just our technologists did not you know, label them correctly. But this is V. Remember V4, and this tracing here in front of you is equivalent to V7. V5 is equivalent to V8. V6 is equivalent to V9, and I'll show you on the picture on the next slide. So ST elevation in V7, 8, and 9, it means there is a posterior infarction, and this looks like a circumflex. So this is the back of the patient. You see the scapula, and this is the left side of the chest, and V7, 8, and 9. So if you see an ST elevation, ST depression, sorry, in V1, 3, like the case we saw, then go and do a posterior leads, and that's what you will see as we demonstrated in our case. Posterior ST elevation is suggestive of an occlusion of a circumflex or any of the large obtuse marginals. And posterior infarction sometimes is not an easy to diagnose on 12-lead ECG. Sometimes when I see a normal ECG and still I feel there's a STEMI, or there's an acute coronary syndrome, and the ECG is not helpful, I usually think of posterior infarction. Dr. Sharif, any comments?
Yeah, it is what you said. This is very important, that we have to understand that to respect the reciprocal chain. This, sorry, the V1, V2, and the V3 ST segment depression. This is very important.
Excellent. Okay. Yes. Now let's move to the next case 9. Case 9, we have 53 overweight lady, diabetic, dyslipidemic, hypertensive with AFib. And she comes with an epigastric pain, dyspnea. She presents to a primary healthcare center, and they do an ECG, and that's her ECG. So
this is the rate. So there is rate, rhythm, axis, interval. So let us go to the rate. The rate is tachycardic, yes?
Yes, yes.
Rhythm, regular or irregular?
It's irregular.
Okay. So the rhythm is irregular. Is there any P wave? You can see P wave?
I cannot see a P waves.
So irregular.
By the way, I mean, those questions, when Dr. Sharif asked them, try to answer them, you know, by yourself. So we can,
of course.
You know,
I'm not asking to Zubaidi. I'm asking
but I'm helping exactly.
Yeah. So rate, rhythm, axis. What is the axis? It's normal, lead 1 AVF.
Normal.
Okay.
Yes.
So rate, rhythm, axis, interval. The QRS complex looks normal. There is nothing, no white complex. PR interval, QT interval, everything looks normal. So now rate, rhythm, axis, interval, segment. What about the segment here? We have in lead 1 and AVL, it looks like slightly elevated in lead 1 AVL. But the most impressing thing, you look lead 1 AVL and V6 looks elevated, but also the impressing thing at V1, V2, V3 till V4. What do you think, Zubaidi?
Yes, so they're very, you know, so as you say, I mean, there's mild ST elevation lead 1 AVL, but very suggestive of a lateral infarction. Of course, V6 again, and V5. So lateral infarction, I think this case I would call lateral definite. And then the second part is the ST depression in lead V1, V2, V3, suggestive of a posterior infarction, as we saw in the previous case. So lateral and posterior in this case. And this can be related to a circumflex. So yes, there is an inferior ST elevation and there is a posterior infarction. Okay. The message I'm trying to link to this case is tachyarrhythmias associated with STEMI. Remember, we talked about bradycardias, complete block, RV infarction, posterior involvement. So arrhythmia again is very, important to watch, and that's the role of the monitor when you hook your patient to the monitor. So, about almost 15 to 40% of the patients, they will get some sort of an accelerated idioventricular rhythm. A lot of time it's benign because of reperfusion. We see it after we open the artery or after we give thrombolysis. But when you open the artery and you see some acceleration, if the hemodynamics are okay, usually we leave those patients. We don't treat it. But if they start to affect hemodynamics, we may treat them. Bradycardia, non-sustained VT, a lot of times you see it, 26% of the patients, every 4 patients, they will have some sort of a non-sustained VT. Sinus tachy is very common, and patients with sinus tachycardia, they do poorly because, it means that they're under a lot of stress or they have a large area of myocardium involved. So sinus tachycardia is a marker of a bad outcome. AFib can happen as a complication of an MI. In this patient, the patient had AFib from before, but it can be a complication in 10%. Every 10 patients with acute MI, one of them will have AFib.
And usually, Dr. Zubaidi, with the inferior MI, because it's the supply for the atrium, the right atrium,
Yes.
All this can indicate atrial infarction. Exactly.
High degree AV block can happen when we saw a couple of cases tonight. Sustained VT and VF 2 to 5%. And those are the patients that will benefit out of the monitoring and shock because, those with AV block, those with sustained VT, and those with VF. So that's why we put these patients on monitors for those life-threatening arrhythmias. The last 3 mainly, high degree AV block, sustained VT, and VF. Because this patient, if they go into this type of arrhythmias, usually if you don't pick them very early in the first few minutes or so, you lose them, or the first seconds even, not minutes. Okay, so arrhythmia is a complication of acute MI, and that's why it's important. It's very important to put these patients on monitor. It's very important to put eyes on the monitor. You have to have someone who sits there and watch the monitor, because you want to pick these arrhythmias very early, and you want to treat them very early, either by shocking the patient or pacing the patient or giving them pharmacological treatment. Either it's atropine or epi or whatever, ACLS protocol decides. So any other comments, Dr. Bakir, about the complications or the tachyarrhythmias associated with MI?
We have to know that with MI, you can have any form of complication. This is electrical complication. This is very important, and to have to be aware about that.
Yeah.
This case,
so I like that point. So acute MI, you can classify the complication. So if you're having this acute MI, usually watch for electrical complication, like what we stated. Look for mechanical complication, severe MR or VSDs, or sometimes rupture, which is a life threatening, or pump failure. So there's a lot of complications that can happen from myocardial infarction. It's not the diagnosis of the MI, it's watching for complications also.
Electrical and mechanical. This is put in your mind.
Mechanical, exactly. Case number 10, demographics.
This is nice. Dr. Zubaidi, this is young. You are going with the age younger and younger, before 49, 48, 45.
Yes, actually, the majority, we looked at the database, our database. Okay, and the mean age of patients who comes with acute MI STEMI is young, in the 40s. So mean age is 48. So a lot of young, 40, 30s, and of course, we have the 50s and 60s. But our population is at least 10 to 12 years younger than other populations we see in the West or Western countries. So the message out of this, younger patients. So young patient, if you lose a young patient, you're losing a person who's in highly productive years. You're losing a person who was responsible about a family. And so number of years lost is so many. So if this patient 45 is not diagnosed, it means, you're losing a lot of working years. And the impact of such patient is very high because such young patient is taking care of a big family a lot of times from what we see. So 45 million.
Yeah, I want to add something, Zubaidi, in this history. You said past medical history non-relevant, but sometimes when you ask the patient, are you diabetic? He said no, but maybe he didn't check his blood sugar. Are you dyslipidemic? He said no, but maybe he didn't check his lipid profile, because all of these are asymptomatic. So be careful about that when you said past medical history, nothing. Maybe he's diabetic and didn't know. Maybe he's dyslipidemic and didn't know. Are you agree with me, Zubaidi?
Yes, definitely. No, I think, sometimes because one of the things with these patients, acute coronary syndrome, is we take a focused history but yes, a lot of times these patients, they don't come, when you dig deep, you find they're hyperlipidemic, you find they're hypertensive, and you find they're diabetic, but they don't check. So the first time they get is the acute MI, and then you find out that they have all the risk factors there. So let's move to the tracing. In this case, 45 with chest pain, 45 years old with chest pain. Rate, rhythm,
axis. We will never put rate, rhythm, axis, interval. So the rate, what is the rate here? Look to how many big square. It's around 3.5. So it is more than 75, more than around 80 something. Yes. Rhythm is, look to the rhythm. I want you, everybody of you, to look to lead 2 down. What is in lead 2? Raised, it is, yes, peak URS complete, but the first beat, you see, there is a prematures, ventricular prematures falling on what? In the dangerous period also. Yes, Zubaidi, or what do you think?
Yes. Sorry, I missed that one.
I'm saying look to the lead 2 down. Lead 2. So the first beat in lead 2.
Yeah, I think there's a ventricular ectopic beat.
Yeah. And
then, and then we can have a sinus rhythm that marches all, and it's regular. But there is already a PVCs, as we saw in the previous ECG. The axis is almost to normal. I mean, it's equivocal.
And it looks like could be right. You are going to the right, but it's normal because in V1 lead the R and S is nearly equal.
Yes. Okay.
But in the V1 bar, you will see something. So rate, rhythm, axis.
In V1, there is an RSR, and so there's a pattern suggestive of a right bundle branch block. And then there's ST elevation involving V1, V2, V3. And then ST depression involving lead 2, 3, lead 2, 3 AVF. So ST depression in the inferior leads, and then ST elevation in the anterior leads.
With right bundle or incomplete right bundle.
In the setting of right bundle branch block. And I have a message out of that I want to convey. So in the early of this presentation, we showed you left bundle branch block, and we talked about the importance of left bundle branch block in acute coronary syndrome. So if you have a left bundle, you treat it as a new STEMI. In right, and usually, we say left bundle interferes with the diagnosis because it's not, that you can't use the ST elevation criteria in left bundle, except if you believe in Scarboza criteria. But in right bundle, usually they say you can diagnose STEMI in the setting of right bundle.
This is a very important point, Dr.
And this statement comes out of the European Society of Cardiology STEMI guidelines. And what they say, the ECG criteria for right bundle is as follows. Okay, so they state that what are the criteria? It's wide, more than 120 milliseconds, and the RSR pattern. But unlike, so this is second paragraph, unlike in the presence of a left bundle branch block, myocardial ischemia and infarction can easily be detected on ECG when a right bundle branch block is present. So when you have a left bundle, you can't look at, you can't assess the ST segments, as I say, but you treat all left bundle as a STEMI. In right bundle, no. If you don't have ST elevation, then it's a right bundle. If you have ST elevation, then there's a right bundle and there's ST elevation there. I hope it's clear. I'm kind of mixed it up, I felt, but I hope I am clear. In the setting of right bundle, you know, you can diagnose STEMI. In the setting of left bundle, you can diagnose, but you treat left bundle as a STEMI. واضح دكتور بكير؟ تقدر توضحها أكثر من كذا؟
What you said, the Brady?
Yeah, I'm saying, you know, left bundle branch block is you know, you can diagnose in the presence of left bundle, so you have to use left bundle as a diagnosis by itself.
But in right, so this
and
is
right usually it doesn't mask MI, so you have a ST elevation, you can diagnose. So this patient has an anterior ST elevation, and he was treated accordingly. Case 11.
You have time, Zubaidi, for the case number 12, or
yeah, we'll do another 2 cases, and I think we'll move to Dr. Lai.
Okay.
Because I have a drill. I mean, if there's more time, but you know, unfortunately, we're going over the
because
time.
we're with a lack of time. Now we reduce the age, now 42.
42. So young patient, chest pain. We did an ECG, and that's his ECG. Again.
Okay, again, rate, rhythm, axis, interval. So rate, it is around 3 big square, yes?
Yes.
Rhythm, it is rhythm, it is looks sinus, P, QRS complex T, P, QRS complex T, it's sinus. Axis, it looks like normal axis. Okay.
Yeah. Yeah.
Interval looks like also normal, PR interval and the QT interval, and the QRS complex look normal. Now we'll go to the segment. What do you think? Lead 1, lead 1 and AVL, and from V2 till V4 or V5, V6.
Yeah.
And
V6.
then you have in the inferior lead ST segment depression.
Yes.
So
sinus rhythm, about 100 rate, but the most important is there is ST elevation involving almost all the anterior and lateral leads. So lead from up, lead V2 down to V6, almost all there is ST elevation. So the anterior leads all are involved. And then you have the lateral leads, high lateral, lead 1 and AVL, there is ST elevation. And then you go down to inferior leads and there's just the depression there. So that is a massive anterior lateral ST elevation myocardial infarction. This patient was rushed and taken to the cath lab, and you can see here, first medical contact to balloon time was 82 minutes, which is a great timing. And this patient was treated appropriately, and he did well. So massive anterior lateral ST elevation and with reciprocal changes. Luckily on the ECG, there's no complications, you know, so we don't have any arrhythmias, we don't have any suggestive of mainly, you know, electrical complications. Male 64 presents with chest pain. Dr. Sharif.
yes, Dr. Zubaidi.
You have the ECG.
Yeah, so the ECG will do again rate, rhythm, axis, interval. Now we are going to how many big square? 1, 2, 3. Yeah, 1, 2, 3, 4, 5.
Yes.
So we are talking about rate around 60 or even less, little bit, because there is one small square. So rate, rhythm, axis, the rate is in the lower limit of normal. And then the rate, rhythm is looks sinus, P, QRS complex T, okay. HP followed by QRS complex. Axis, the axis is looks like left, but if you look to lead 2, you'll find the R more than the S, so it is normal left axis, because we said they have 2 types of left, one normal and one abnormal. If the lead 2, the S is more than the R, it is no abnormal left axis. If they are equal, it's minus 30. If the R is taller, it is normal left axis. So rate, rhythm, axis, interval, it looks normal. The problem will come with the ST segment in lead 2 and lead 3, and the AVF looks elevated. And if you look to the lateral lead 1 and the AVL and the V6, it is elevated. and then you have ST segment depression from V1 to V3, even to V4. So what does it mean, Dr. Zubeidi? You already explained before. Can you explain for them again?
Yeah, so sinus again, regular, but there's ST elevation involving the inferior leads and ST depression involving the anterior leads. When you see those ST depression and the anterior leads in V1, V2, V3 in association with inferior ST elevation. So ST depression, but associated with inferior, think about posterior infarction. And that's the case here. So we did posterior. And as you say here, V7, 8, and 9, there's ST elevation. We showed this case or similar case before, and just another demonstration that if you see ST depression in lead V1, V2, V3, think about posterior. What does that mean? It means that there is a posterior involvement, there's inferior involvement, there's a lateral involvement. That's a very large infarction. That's a poor prognosis. So you have to act rapidly and you have to anticipate complications. If they happen, you have to be prepared for those complications and treat them accordingly. So I think this is the last case, and I plan to give more ECG tracing, but I don't think we have enough time because we are getting close to 9 o'clock, and still we have a talk by Dr. loG Abu Dakka. So
can I interrupt you 1 minute, Dr. Zubeidi? The most important presentation today was the one with normal ECG.
Yes. Yeah, exactly. So that's
very important message.
Yeah. So what do you want to send? So you're saying
No, I'm saying every of them was important, but the take-home message very important.
Yeah.
Don't discharge anybody with chest pain because of ECG is normal.
Yes. Yeah, ECG helps you in the diagnosis, but it doesn't help you in ruling out. So just make sure that, before you send your patient, even with a normal ECG, that you are sure that the clinical presentation does not match acute.
And there's a second one, as you present for us, Dr. Zubeidi, many cases with young, 42 and even younger.
Yes.
So this is the age is not a barrier for you to diagnose myocardial infarction.
Yeah, so don't lead so the message I think Dr. Bakir is trying to convey is, young age doesn't mean that it's not cardiac, so because we see some of our colleagues, they think about, acute MI, something in the 50s or 60s or 70s. But remember, in our population, we see a lot of MIs in the 40s. We see also a lot of MIs in the 30s. Our cases today, I don't know the number, but we have 12, we show 12 cases, probably more than half of them are in the 40s. And I didn't go and select them intentionally, it's just by chance. So this is kind of random selection. So remember that, young age does not rule out, normal ECG does not rule out. And sometimes females also can mislead you. So females can also have an acute MI, and a lot of us, we don't.
But this today, Dr. Zubeidi, we missed one important ECG because of the time, which is the pericarditis.
Yes, yeah. We tried to, to match. I had them on the drill, a lot of pericarditis, other ECG, ST elevations that mimics acute MI, like pericarditis, like pulmonary embolism, like early repolarization, myocarditis, and so on. So yes, those are the, there's a lot to be honest with you, in STEMI that we can talk about, either it's the diagnosis, or it's the complications, or it's the differential diagnosis of STEMI, and of course the non-STEMI cases. And we didn't talk about the management. So of course, there's a lot to talk about in the management. I know it's it's short, but thank you, Dr. Bakir. You did a great job in helping me deliver this, and I hope our colleagues, the audience, we were able to send them a message and add some value to them in this session. Now, just for the sake of time, Dr. loG Abu Dakka, أخبارك?
الله
You have
يسلمك
it.
دكتور.
يعطيك العافية.
الله.
So, you know, I know you have a talk. يعني unfortunately, I don't have the, you know, the title of it here.
It's about hyperkalemia, Dr.
Hyperkalemia, Dr. Zubayd, is
Exactly.
hyperkalemia, which is the topic
it's
everywhere.
Yeah,
because there are no...
I'm trying, يعني, that's why you saw me distracted in the last minute, but I was trying to find out the title so I can present it.
Yeah.
I know it's industry symposia. It's sponsored by Vifor, which has a product to treat hyperkalemia. From physiology to clinical practice. I like that name. يعطيك العافية.
Allah يعافيك. Thank you very much, Dr. Zubaidi and Dr. Sharif, for such a fruitful. You made the ECG very easy. ECG is a very important, very cheap test, you know, which can save lives, especially the lethal, you know, arrhythmias, brady or tachy, and the ST elevations. And I believe every medical school graduate or physicians should know these ECGs very well. It was a very nice cases, and it was well explained and a very simple way that even non-physicians can learn it easily. I will not take much of time. It's a great pleasure and honor for me to present. I would like to say Assalamu alaikum and good evening for our audience tonight. I will talk about hyperkalemia from physiology to clinical practice, a very important subject. Unfortunately, I will not talk today about the ECG changes of hyperkalemia. We know that any electrolytes imbalance, and especially, you know, hyperkalemia can give us a lot of things on the ECG. Before I start, I would like to mention that today I will talk, as Dr. Sharif said, about the novel drugs. There is a new two drugs that made recently to help us managing hyperkalemia and especially the chronic hyperkalemia. For over 50 years, you know, there have been a limited options for the management of hyperkalemia, especially among patients with chronic kidney disease, diabetic nephropathies, those patients with hypertension and heart failure who were receiving concomitant, you know, renin-angiotensin-aldosterone system inhibitors therapy. And we know also that hyperkalemia is a lethal conditions and it needs to be managed. I will not discuss the management at the ER. Everyone knows that we stabilize the membrane at the emergency department when we do have a patient with hyperkalemia. We give calcium gluconate, we give, you know, the insulin, dextrose, we give the salbutamol, which is the beta agonist to push the potassium inside. I will discuss the hyperkalemia in the chronic states. These are the objectives of my talk. I will discuss with you the renin-angiotensin-aldosterone system inhibitors benefits in patients with heart failure. And this is a very important, you know, pick up or starting of the talk because we know those patients receive, you know, a lot of FRASI inhibitors as per the guideline that will help in reducing the mortality and giving a very good outcome. And those medication also will lead to hyperkalemia. Hyperkalemia incidence in patients with heart failure, as I told you earlier, which is frequent, leads to a suboptimal RASI treatment, resulting in worse outcomes. Traditional treatment strategies for chronic hyperkalemia, I will go quickly through the traditional treatment strategies, and I will discuss the new and the novel drugs, the Patiromer efficacy and safety profile, which will allow us, you know, to maximize the RASI and will not discontinue it for our patient, the heart failure patients. Guideline recommended RASI therapy to improve the outcome on patients with heart failure. These are the latest guidelines by the European Society of Cardiology 2021. And these are the pillars, okay, of management for those patients with heart failure and reduced ejection fraction. All of us knows that reduced ejection fraction heart failure patient, they do have a left ventricular ejection fraction of 40% or less. And we know the four classes of the drugs, which are the ACE inhibitors, the angiotensin converting inhibitors, or the ARNI, one of them. We cannot use both together for sure. Beta blockers, the MRA, the mineralocorticoids antagonist, and of course, the novel one, which is the sodium glucose co-transporter 2 inhibitors, the dapagliflozin and the empagliflozin. Okay, so what are these four pillars do for our heart failure patient? This improves the survival of our patients, reduce the risk of heart failure hospitalizations and reduce the symptoms in patients with heart failure and reduce ejection fraction. So they are a cornerstone therapies, and we should up-titrate them to the doses used on the clinical trials. For example, in the paradigm on heart failure, or in the DAPA-HF, or any study conducted regarding these medication. So we have to reach the maximally tolerated doses if possible. And when we add the SGLT2 inhibitors to the ACE or ARNIs or beta blockers or MRAs, these drugs will offer us more reduction on the risk of cardiovascular death, and it will reduce the worsening of heart failure in our patients. Again, these four classes of the drug plus the sacubitril/valsartan, which are the ARNIs, plus the beta blockers, are all class 1 with a level of evidence A for most of them, except for the sacubitril/valsartan, it's class 1B. We recommend it for those patients with HFrEF, يعني heart failure with reduced ejection fraction, to reduce the risk of heart failure, hospitalization, and death. And we should, as per the guideline, to up-titrate these medication up to the maximally tolerated doses if it is possible. This is a systematic review of 57, randomized clinical trials were published between the year of 1987 and 2015. And here they want to, evaluate and they want to identify the recommended drug classes in a combination for those patients with HFrEF. And they found out that the RASi inhibitors, which are the ARNIs, MRAs, and the ACE inhibitors, when combined with the beta blocker, they give better, reduction in all-cause mortality compared to the placebo. And if you add the ARNI to the combinations, the new one which came like a few years back, you will get the greatest reduction in all-cause mortality. Another few studies, for the ACE inhibitors and ARBs, angiotensin receptor blockers like the losartan, and the ACE inhibitors like the zinobril on the ATLAS, SECURE, and HEALS, shows that high renin-angiotensin-aldosterone system inhibitors, offer increased cardiovascular risk protection, compared to a lower dose. And you will get more reduction on all-cause mortality, more risk reduction on heart failure hospitalization, and even in cardiovascular mortality and hospitalization. So giving a higher dose of renin-angiotensin-aldosterone inhibitors to your patient will offer you more protection than giving the half dose or a lower dose than the recommended doses. Let's come to the hyperkalemia as an incidence in those heart failure patients, and which leads frequently to suboptimal, RASi treatment, and this will result in worse outcome. This study was published back in 2020, and here, they want to assess, in a sample of patients, they want to assess the prevalence of hyperkalemia in 1 year in different type of patients with comorbidities like the chronic kidney disease, the heart failure, the diabetes, hypertension, and those with no comorbidities. And they found that the prevalence of hyperkalemia is highest in individuals with a chronic kidney disease here and heart failure, and lowest in individuals without underlying comorbidities. For heart failure alone, the hyperkalemia prevalence across a calendar year was between 8.6 and 9.4%. Imagine almost 10% of your patient will develop hyperkalemia, whatever is it, mild, moderate, or high, severe, I mean. Okay, again, another study from the real world patients with heart failure. Here they want to investigate a 1 year incidence of dyslipidemia, I mean hyper or hypokalemia, on those patients with all ranges of heart failure. I mean here the heart failure with preserved ejection fraction, mid-range ejection fraction, and preserved ejection fraction. What they found out that 24.4% of participants experienced at least one mild hyperkalemia event within a year of follow-up. And another 10.2% had a moderate to severe hyperkalemia within a year of follow-up. Adjusted risk of moderate to severe hyperkalemia was highest on those patients with HFpEF and HF mid-range ejection fraction. And this is explained that those patients may receive less, RASi inhibitors, while for those patients with HFrEF, they received a lot of, RAS inhibitors, and especially the MRAs. These are the serious clinical consequences of a chronic hyperkalemia. We know it affects the cardiac excitability, and it may lead to lethal arrhythmias. It increases also the secretion of aldosterone. Hyperkalemia, when will be chronic, the aldosterone will be more, and this may cause vascular damage, vascular inflammation, renal fibrosis, endothelial dysfunctions, peripheral fibrosis, ventricular hypertrophy, ventricular remodeling, and sympathomimetic activation. Also, at the level of neurorenal excitability, it may cause uremic neuropathies. And also sometimes hyperkalemia in a chronic fashion, it may lead to a type 4 renal tubular acidosis, and all these will lead to a hypertension or stroke, heart failure, or even renal failure. So hyperkalemia, if left untreated, it will affect our body organs and it will cause lethal diseases. Here in this study, they want to see the association between the increased risk on those patients with heart failure and the chronic kidney disease with hyperkalemia. We can see clearly here, this is, by the way, from a big registry with about 910,000 patients evaluated for hyperkalemia, normokalemia, and hypokalemia while taking, potassium-lowering therapies. And we can see the U-shaped association between the serum potassium and all-cause mortality with potassium outside of the normal range, either hyper or hypokalemia. All-cause mortality was significantly elevated for every 1 milliequivalent per liter change on the serum potassium below 4 and more than, or 5 or more than 5. Patients elder than 65 years or 65 or more with heart failure or chronic kidney disease or diabetes mellitus had a higher adjusted mortality across all potassium levels versus those subjects on the age ranges between 50 and 64 with any other specified disease states. Here is the story of our, RASi inhibitors, the renin inhibitors, the ACE inhibitors, and all of us knows how it works. All of them, they will lead to a potassium retention, and especially the MRA, and that's why we call it the potassium sparing, diuretics, the spironolactone. So the hyperkalemia is an inherent risk of the treatment with all these drugs. The rates of severe hyperkalemia in heart failure patients receiving the mineralocorticosteroid antagonist, the aldosterone, ranges in the clinical trials between 2 and 5.5%. And in a large clinical practice trials, the range will be between 6 and 12%. So when you use the spironolactones, you have a higher chances for your patient to get hyperkalemia, and these are pulled from a large trials like the RAILS, the EPHASIS, and also from a smaller trial on the clinical practice. So you have a higher percentage of patients with hyperkalemia when you give your patients MRAs. So we have a dilemma here between the hyperkalemia risk versus the benefit of our agents, the renin-angiotensin-aldosterone system inhibitors. And we have to solve it because we want our heart failure patient or hypertensive patient or those who are receiving the RASi to be on the maximum tolerated dose as per the guidelines. Here are the recommendations for the laboratory monitoring of potassium, serum potassium, when you use the RASi inhibitors. In 2021, the guideline recommended that we have to check the renal function and electrolytes when we start the ACE inhibitors, ARBs or ARNIs. We have to recheck the blood chemistry, urea, blood urea nitrogen, creatinine, serum potassium, 1 to 2 weeks after initiation, and 1 to 2 weeks after final dose titration. Monitor the blood chemistry 4 monthly thereafter. You don't leave your patient on the medication without doing regularly a checkup for the blood, for their renal and electrolytes function. For the MRAs, it's more tight. The guideline asked us to check the renal function and electrolytes, particularly the serum potassium, and then you have to check the blood chemistry at 1 and 4 weeks after starting or increasing the dose, and at 8 and 12, 6, 9, and 12 months. 8 and 12 weeks, then every 3 months, not every 4 months for a year, then 4 monthly. Why they became more, cautious over here? Because we know that the spironolactone, the MRA, will spare the potassium. The chances of getting hyperkalemia is more, and that's why they want a strict follow-up for the serum potassium. This slides, I want to show you how hyperkalemia will lead to a down titration of the RASI or dose reduction, or sometimes discontinuations. Here to the left of the screen, you can see those with mild hyperkalemia, their potassium level between 5.1 and 5.4, and to the right, you can see those with moderate to severe hyperkalemia. Over here, we can see that after a hyperkalemic events among those patients with cardiorenal comorbidities, on a maximal RASI tolerated dose, there was a 38% of them got mild hyperkalemia. And on those who got severe to moderate, 47% of them got moderate to severe hyperkalemia, which lead to down titration or discontinuations of the RAS inhibitors. Another slide, it's a study, we call it Qualify. This study was about 7,000 patients at international prospective studies where they recruited an outpatients with chronic heart failure and recruited between 1 and 15 months after hospitalization for heart failure. I want you to notice these colors on the blue, the hyperkalemia here, why they discontinued the RASI or the drugs, all the RASI drugs, the ACE inhibitors, the MRA, the ARBs. In this study, the Entresto or the ARNIs were not included, but you can see on the MRA, 31.4% of those patients who got discontinued, the MRA is due to hyperkalemia. In the ARBs, 5.5%, and on the ACE inhibitors, 4%. Very high risk populations with hypertension, diabetes, chronic kidney disease, and 82% of them were in class 2 to 3 NIA functional class for the heart failure. MRAs, again, MRAs are frequently underused, and this is information came from a large real-world trials like the GWTG-HF, Improve HF, the Euro Heart Failure Survey, and the other CHAMP and the Swedish Heart Failure. We can see that, only 40 to 50% of the population of these registries are on the MRA. And this underuse, it's not only maybe because of the hyperkalemia, maybe non-specialist care, the patient is not visiting a heart failure specialist, maybe also it is due to suboptimal dosing of the ACE or ARBs, you cannot add it because of the hypotensions, or also because of the renal function by itself. Another real-world data indicate the optimal RASI use on those patients with heart failure that result into increased rate of the MACE, the major adverse cardiac events, and the mortality. Here you see those patients who are their RASI doses are less than 50%. You can see and compare between these two columns that the MACE increased dramatically. And again, for the mortality, when those patients are receiving less than 50% of the recommended dose, the mortality will increase compared to those patients who are receiving more than 50% of the recommended dose. This was published on the Journal of American Heart Associations in 2019. Let's see quickly the traditional treatment strategies for chronic hyperkalemia. Of course, first of all, you will ask your patient to cut down the dietary potassium supply, like the bananas, broccolis, avocados, but there is also a limitations. We know that our heart failure patient or chronic kidney disease patients already, they do have a lot of restricted diets to go with it. And we know all these potassium containing diets are a healthy food, and you are restricting a healthy food. Low in fresh fruits, vegetables, and very low in fibers. Increase the risk of cardiovascular disease and stroke if you cut these healthy diets. The compliance also is low. Maybe your patient will follow your instructions for 1 month, 2 months, then he will go back to his normal habits. To reduce the renin-angiotensin-aldosterone system inhibitors, there will be an increased risk of MACE and mortality, as we saw before with the previous slides. Non-potassium sparing diuretics like the loop diuretics, and we know these do have advantages and disadvantage. Over diuresis is not that much good for our heart failure patient. Even it's not good for those patients with a chronic kidney disease. You are pushing the kidney to for diuresis, and this may worsen the kidney function. So it is not the absolute solutions. We do have also the traditional potassium binders, the calcium polystyrene sulfonate and the sodium polystyrene sulfonates. They are not well tolerated. The taste is very bad. Patient cannot continue on it. You have to take it more than once a day, and you have to stop it once the potassium level is below 5. We do have a lot of GI adverse effects like intestinal necrosis, and sometimes it's associated with a very severe GI adverse events. So it was not that much recommended for the patient. Even patient by themselves, they will not tolerate the taste of these CPS and SPS, potassium binders medication. Let's talk more about the loop diuretics as a management of hyperkalemia, and I will show you how these loop diuretics give advantages and disadvantages. We know that it enhances the excretion of potassium by the kidneys. The onset of the action depends when you will start the diuresis, and the their beneficial in patient with volume expansion is awesome. The patients will lose weight. The disadvantages that efficacy depends on the residual renal function. This is a very important point. Important side effects include increased risk for gout, diabetes, volume contractions, worsening of renal function, and reduced potassium excretion. Risk of sarcopenia also is there. So the use of high doses of loop diuretics will limit up titration of the other heart failure medications in patients with heart failure and is associated with worse outcome. What the latest guideline tell us about the loop diuretics for those patients with heart failure? The aim of diuretics, as we know, is to achieve and to maintain euvolemia with the lowest diuretic dose. And in some euvolemic and hypovolemic patients, the use of the loop diuretics drugs might be reduced or even discontinued. Patients should be trained to self-adjust their diuretics dose based on the monitoring of symptoms, signs of congestion, and daily body weight. We know before the heart failure nurse or the heart failure clinic nurse will call the patient, will ask him about his body weight, about his symptoms, and will reduce or increase his, furosemide or his any, diuretics. But now the guidelines are recommended that the patient himself should learn how to deal with his diuretics to increase it or decrease it according to the symptoms and signs. Again, from the real world practice, the decreased doses of the loop diuretics will be associated with a better clinical outcome on patients with heart failure. So here, this is a study which enrolled about 8,000 patients with a heart failure from a European registry between 2011 and 2016, and they want to investigate the loop diuretics dose changes on a daily cardiology practice and their association with the clinical outcome. The low rates of loop diuretics does decrease at outpatient visit were observed by 9%, and the loop diuretics doses decreases was associated with more favorable cardiovascular outcome. So if the loop diuretics dose decrease, it was associated with an almost 40% risk reduction on heart failure and cardiovascular mortality. If the loop diuretics dose increase, it was associated with up to 50% increase in risk of heart failure and cardiovascular mortality. Back to the 2021 European Society of Cardiology guidelines for the management of hyperkalemia, they mentioned clearly that both compounds, patiromir and the sodium zirconium, are effective in normalizing elevated potassium levels, maintaining normokalemia over time, and preventing the recurrence of hyperkalemia, and can be considered for the treatment of hyperkalemia. So, administration of the potassium-lowering agent, patiromir or sodium zirconium, may allow renin-angiotensin-aldosterone system inhibitors initiation or up-titration in a larger proportion of patients. So they advise us to use these, compounds that we can adjust and up-titrate, initiate or up-titrate our RASi inhibitors. These are some considerations also from the European Society of Cardiology 2021 guidelines. If you do have a patient with normokalemia, his potassium between 4.5 and 5, if he is not on maximal tolerated guideline recommended target dose of RASi, then initiate or up-titrate with a close monitoring of the potassium. Initiate potassium lowering agents if his potassium will be more than 5. If mild to moderate hyperkalemia, and here they redefined it, it's now 5 to 6.5, initiate potassium lowering agent, closely monitor the potassium levels, maintain unless alternative treatable etiology is identified. And if not on maximal tolerated guideline recommended target dose of RASi, optimize the RASi when the potassium level fall below 5. For those with severe hyperkalemia, serum potassium level more than 6.5, discontinue or reduce the RASi, initiate the potassium lowering agent, and closely monitor the potassium level. Let's talk about our agent, the patiromir, which has an established efficacy and safety profile that allow us to initiate or up-titrate our RAS inhibitors.
That's for the second time, Dr. Laya.
I will try to go very quickly. Okay, the patiromir as a binder for the potassium, it's a carboxylated groups of patiromir bind to the potassium in exchange for the calcium, not for the sodium, and this is very important. The beads of the patiromir excreted and leading to removal of excess potassium and reduction on the serum potassium levels. It's spherical, smooth, uniform microbeads with free flowing properties. It works at the distal colon. It must be taken separated between the drugs, other drugs, by 3 hours. It was studied in intensive program. I will go quickly through these things, but because of the sake of the time, I will be more faster. This is the program for the patiromir. We do have a lot of studies, the pure HF, the OPAL, and the emistis. They recruited a lot of patients. 99.5% of the patients were on RAS inhibitors. 87% of the patients were chronic kidney disease, 65% diabetic, and about 50% had a heart failure. In the pure HF, we can see clearly that the difference in the response between the treatment group was statistically significant at every major time point starting from day 3, which is day 2 after the initiation of the study medication, and it continued up to day 28. Again, on the pure heart failure, there was a significant more patient with heart failure who had a spironolactone dose increased when we start the patiromir compared to the placebo. So we can start our aldactone, and we can titrate it to a 50 milligram per day when we are on the patiromir. In the emisist, D and the patiromir led to a significant and sustained reduction on the potassium level, and the compliance rate were very high, between 86% to 95.9%. OPAL HK, the patiromir, effectively, reduced the potassium level regardless of the baseline potassium, and this was seen very clearly on those patients with heart failure or chronic kidney disease, and 100% of this study population were on the RAS inhibitors. Again, from the OPAL heart failure, they randomized the patients again to placebo and patiromir, and we can see that the proportions of patients on RAS inhibitors at the end of the studies at 8 weeks randomized were 100% because of the Patromir compared only to 55%. The AMPER here, they enabled, the Patromir enabled more persistent use of the spironolactone, and the primary endpoint from this study were that patient who remained on the spironolactone at 12 weeks, 86% compared to only 66% on the placebo arm continue to be on the aldactone with the help of the Patromir. These are all the studies, the OPAL, peer heart failure, and AMPER. It showed clearly that the Patromir enabled substantially more patients to remain on their RAS inhibitors and to initiate or continue or even to up-titrate the aldactone, spironolactone in patients with heart failure and or chronic kidney disease. Diamond is an ongoing study. Maybe the result will come in 2022. There was some adjustment for the primary endpoints because of the COVID, and they are looking after the change of the serum potassium level from the baseline. We will wait for the result of these studies. This is another real-world management of hyperkalemia with Patromir, and which was associated with the high rates of RAS inhibitors continuation. We can see here from at 1 month, 3 months, and 6 months that potassium concentration reductions post-Patromir initiation was average of almost 1 milliequivalent per liter. And through the 6 months, the therapy was continued, the RAS inhibitor therapies was continued on all the patients. The safety profile of the Patromir is very good. It was studied in a very good way. Very few hypomagnesemia, but there is no hypocalcemia because this drug is working on the distal colon. And there was fewer constipations, diarrhea, or abdominal pain noticed, very rare nausea and vomitings, so the drug is safe. Interaction, there was a few drugs which will interact like the ciprofloxacin, levothyroxine, maybe also the metformin and the quinidine. That's why they advise to give the drug separated by at least 3 hours from the other oral medications. Here are another safety, studies and analysis, and this is from the real world, studies, real world registries. Hypomagnesemia and the blood magnesium decreased were observed only on 5.3% and 0.8% of patients in the clinical trial program. Hypercalcemia was observed in a single patient, which is 0.2%. As I told you, it will not cause hypercalcemia. Let's discuss quickly the sodium zirconium cyclosilicate, which is another agent, but here they use a sodium. So it's sodium-based potassium binder, insoluble, inorganic, and it have a potassium selective cation exchanger with high exchange capacity and selectivity for potassium and ammonium ions. It has approximately 400 milligram sodium per 5 gram doses, which is not good for our heart failure patient. Especially, you need a loading dose of every 8 hours in the first 2 days or 48 hours. The good thing about the sodium zirconium that the onset of action is faster than our Patromir. Here in 1 hour, over there it takes 4 to 7 hours. As I told you, the administration includes a correction phase of 10 grams 3 times daily and a maintenance dose starting from 5 grams every day. They do report a hypokalemia and an edema-related events, and this is because of the sodium. This is the harmonized study for the sodium zirconium. The safety, as I told you, the hypokalemia and the edema were common and recorded. In summary, renin-angiotensin-aldosterone system inhibitors therapy are the cornerstone of the treatment for the heart failure, and it forms 2 of the 4 pillars of heart failure treatment. By the way, also the SGLT2 inhibitors and the beta blocker, it may cause some form of hyperkalemia. Guideline recommended RASI therapy improves the outcome in our patient with heart failure, but also it increases the risk of hyperkalemia. Hyperkalemia incidence is high in patients with heart failure and can have a serious clinical consequences. Chronic hyperkalemia frequently leads to RASI down titration or even discontinuation on patients with heart failure. Traditional treatment options for chronic hyperkalemia are limited and may not be suitable for a long-term use. The recent European Society of Cardiology heart failure guidelines indicate that administration of the novel potassium lowering agent may allow RASI initiation or up titration in a large proportion of patients. Bakir, a next generation potassium binder that has been investigated in clinical studies in a large range of patients. Bakir demonstrated significant and clinically meaningful serum potassium reduction with maintenance of long-term serum potassium control and the ability to keep patients on RASI medication. The safety profile has been confirmed across clinical trials and in clinical practice. Thank you very much for your attention. I'm sorry for getting extra minutes.
Thank you, Dr. Lai. Thank you so much. I think it's great talk, and it elaborates how important hyperkalemia is underdiagnosed and not treated proper, and the risk of hyperkalemia. Just I'm going to take one question, and then we'll come to a closure just because of the time. What serum creatinine level ACE or ARB should not be used, or when should they be used carefully? What's your, what kind of serum creatinine would you look at before you say, I'm not going to use an ARB for a heart failure patient?
That's very good questions. Okay, it depends all about the EGFR. Are you initiating, or if this patient are in ACE or ARBs inhibitor, also it makes a big difference. If your patient has a chronic kidney disease, and if his EGFR is low, maybe it's not advisable to go on with the ACE or ARBs inhibitors. But if your patient is already on, initially, if the patient is having a normal creatinine, it might rise a little bit, but it will come back to the normal. But if the patient is receiving the ACE and the ARBs and his renal function is deteriorating, it is advised to discontinue the ACE or the ARBs medication.
Great. Thank you, Dr. Lai. I think this is great. Just because of the time, I think we need to come to the end of this session. I'm just looking at the chat box and at the comments, and thank you to all our participants. A lot of appreciation and thanks and interaction in the question answer, and also in the chat from our colleagues. They talk about how useful this is and how simple it is. I think the credit goes to also to my co-chair in this, Dr. Sharif Bakir. He puts a lot of effort and time. Thank you, Dr. Sharif. Thanks to our sponsor, for their unrestricted support on this for this session, and our colleagues in ICOM for the organization. Dr. Lai, thank you for your talk. It was great, nicely illustrated talk on hyperkalemia, and I hope this was useful. We'll stay tuned. We'll keep this ECG symposia done periodically, and we will announce as it comes, inshallah. Thank you again, and have a good night.
Thank you, Dr. Zubaidi.
Thank you.